Good evening. Thanks to each and every one of you for being here with us today. I, Ankit Dogra, along with my teammates, Dr. Deepika Chhabra and Mr. Amit Saxena from Medical Services and Mr. Vijay Kumar, Zonal Sales Manager, North Zone from Naari Division of Jagsonpal Pharmaceuticals Ltd, are very pleased to welcome you all to the program on Recurrent IVF Failure, How to Improve Results, organized by IFS Haryana Chapter and Rewari Obs Gyn Society, with academic partner Naari Division of Jagsonpal Pharmaceuticals Ltd, makers of PRORETRO, 10 mg tablets of micronized Dydrogesterone, assisting motherhood, delivering happiness. We also present ENDOREG, dienogest 2 mg tablets for the management of endometriosis and endometriosis-associated pelvic pain, and FIBRISTONE, 25 mg tablets of mifepristone, safer alternative to surgical management of uterine fibroids. Dear attendees, if you have any questions, suggestions, or clarifications, please post in the Q&A box. Please note this webinar is streaming live on the Facebook. The link is shared in chat box. Also note, for future reference, we'll upload this webinar on our YouTube channel, Jagsonpal Medical Insights. Now let us welcome the convener of the program, Dr. Seema Mittal, Treasurer, Haryana Chapter IFS, and past President, Rewari Obs Gyn Society, to kindly initiate the program. Over to you, ma'am.
Thanks, Ankit ji. Thank you, Deepika ji. Hello and welcome to this webinar, and thank you for taking time out and being with us. Friends, on behalf of Haryana Chapter of IFS, we dedicate this webinar to all those patients who fail to conceive in spite of repeated attempts at IVF cycle. Friends, as we know that human production is inefficient, as is evidenced by mean delivery rate of 37.3% from embryo transfer in IVF cycles. Despite advances in assisted reproductive techniques over 4 decades, there are patients who fail to achieve live births following multiple IVF cycles. Although delivery rates have improved, but in the majority of failed implantation cases, no identifiable etiology is found. So, isolating a specific cause for recurrent implantation failure can be challenging. The endometrial receptivity, the culture techniques, and the embryo transfer modalities all affect the outcome of our results. So today we have wonderful galaxy of speakers and our guests. We have experts, Professor Sudha Prasad ma'am, who is our President IFS and India, and Dr. Sonia Malik ma'am, who needs no introduction, and Dr. K.D. Nair sir and Dr. Abba Mazumdar to speak on the subject. And we really hope that after the webinar, we will have an insight to improve our results and do justification to our patients. And now I request our Secretary Haryana Chapter, Dr. Sonu Balhara, to welcome all our audience and the speakers and the faculty for today's webinar. Over to you, Dr. Sonu.
Thank you so much, Seema. Good afternoon, everyone. My seniors, Sonia ma'am, Sudha ma'am, Abha ma'am, and all my friends and our viewers. I welcome you all on behalf of our Haryana chapter of Indian Fertility Society on this important topic. I know our esteemed faculty will share all the experiences on the endometrium, ET, and the lab ambience. And not wasting much time, I would like to thank Sudha ma'am for giving us the Best Chapter Award, our Haryana team, for the last session. And hopefully this year also, we will keep up the same pace. Thank you so much, ma'am. And I invite you to say a few words. I'll just give ma'am's short CV. She is our own president of our society, Indian Fertility Society, and Director, Matritava and Advanced IVF and Training Center, New Delhi. Ma'am has more than 34 years of experience, and she is former professor and IVF coordinator at Maulana Azad College, New Delhi. Ma'am, please say a few words. Thank you so much.
Thank you, Dr. Sonu, and good evening to all of you. It's a great opportunity, and I just congratulate Dr. Sonu, Dr. Seema, for taking a very important topic for the webinar. It's important. Why? Because it is very challenging, and simultaneously it is frustrating also for the clinician as well as the patient. you keep on doing, and if the success is not there. So we exactly do not know what can be the reason. So this is very important one, where we do not know what exactly the definition is. Somebody says 2 IVF failures, some other definition says 3 IVF failures, some says 2 or 3 embryo, good quality embryo transfers. So starting from the definition to the treatment, to the management, everything is very challenging. So I hope you have kept so many good, strong speakers for this webinar, and I hope the listeners will take a very good take-home message. And finally, the clinician really requires what? Requires a good tips for these kind of patient, where we can have at least 1% or 0.1% success rate of RIF. That gives a smile on the clinician that yes, we have succeeded when there is a failures of the patients. So I hope you will get a very good take-home message by the renowned speakers, and finally you will use it in your clinical practice. Thank you very much for calling me, and I really congratulate Seema, the way Seema and the Sonu are working at Haryana chapter. I hope you will have the another trophy, from the Indian Fertility Society, because you are working very hard and taking the flag of IFS at very, very high. Thank you so much.
Thank you, ma'am. Thank you so much. Your blessings and your expertise is really helping us a long way, and we would like to stay with you forever. And now I request our chairpersons for the session to call the most eminent speaker of our today's evening, like how Sachin Tendulkar is to cricket team, ma'am is to IFS, not IFS. Indian fertility scenario has been changed by madam, that we will know in her CV. And it's always a pleasure to be with you, ma'am. You make us so comfortable in every aspect. So our first chairperson for this is Dr. Neeru Thakral. Dr. Neeru Thakral is our past secretary, Haryana chapter. She is director of office, Thakral International IVF Center, and she has presented many papers, presentations, and she's been organizing chairperson for first annual conference, and chairperson for this session, Dr. Shalu Gupta. Dr. Shalu Gupta, we have to change. Actually, Pooja will be for last session. Can we have Dr. Shalu's CV here? Yes, Dr. Shalu Gupta is Associate Director, Cloud9 Hospital, Gurugram, and her areas of interest are poor awareness of recurrent implantation failure and PCOS. She's presented many papers, and knowing her personally, I know she is very, very expert in the subject, and she's a very nice human being. And it's really pleasure to be with you, Dr. Shalu. So over to Dr. Neeru and Dr. Shalu to introduce the star speaker of our today's evening, Dr. Sonia Malik, ma'am.
Thank you, Seema. Thanks, Dr. Sudha ma'am, for sharing the blessings. Actually, Dr. Sonia Malik ma'am, she needs no introduction. She is the heart and soul of our Haryana chapter and whole of the IFS, I could say. She is past president, Indian Fertility Society 2014. She is chairperson of the Infertility Committee, FOXY 2014 to 16. Past president, Indian Menopause Society. Associate editor of the South Asian Journal of Global Health.
Member. I think we can leave that. I think we can just leave it. Thank you.
I think, ma'am,
member of editor of so many societies.
तुमने अभी बोला I am a part of the Haryana Society, so let it be that. That's it.
Okay, ma'am. Thank you, ma'am. Thanks a lot.
So much. Yeah. Okay. You want to continue and say something?
Yes, ma'am will be speaking on difficulties encountered during OPO and ET. So we as an IVF specialist do face a lot of difficulties. So we want now the tips and tricks which ma'am is going to tell us how to move forward when we get stuck in OPO and ET. Ma'am, to you, over to you now.
Yeah. Yes, ma'am. Let's hear Dr. Sonia, ma'am.
So let me first thank the Haryana chapter, my own chapter, for having me here today. Thank you so much. It is indeed always a pleasure to be amongst all of us. And it is, like Dr. Sudha said, a very proud moment for us to see you all grow. And I must congratulate Neeru also, because she set the ball rolling. She actually pushed the Haryana chapter And, she has brought it to this level, and Sonu has been handed over a very robust chapter. And she, of course, is not anyway behind. She's taking it forward. We are all very, very proud of the past and present teams of Haryana.
Thanks
So with
a lot.
that the first thing that I would want to request all of you is that I was told by Seema and Sonu that I'm to speak only on ET. So I have not prepared anything on OPU. I'm going to just show you a couple of slides at the end of it, but I will concentrate mainly on the ET part of it. So with that, I share my screen with you. And I hope this is going to be in something which is interesting for all of us. Okay, here you are. So a difficult or a challenging embryo transfer is something which is always bothering us and which we are always scared of, because it is the last step to an IVF cycle that we have to actually be monitoring. And therefore, we are very, very scared as to whether we will be able to do justice to it. So challenge is something that puts you on to test. It's like running your first marathon or doing something which is impossible, And so basically that is exactly what we are doing in IVF. Now, the challenges of ARTR, we are not sure of the outcome, and we are very concerned of the safety of the patient. Both these things are our challenges and our problems as well. And as this webinar is very nicely put it, the causes of failure are embryo, endometrium, and embryo transfer. The other two speakers, the other stalwarts, are going to speak on the embryo part of it, which is the lab development, and endometrium, which Abha is going to talk about. So I shall be talking about embryo transfer, the challenges. What is a difficult, what challenges can we have? The challenges may be before, during, and even after the ET. Before, what you can have is uterine pathologies, cavity distortions, embryology problems or dilemmas. And of course, during, it is a difficult ET. Post transfer, it could be an ectopic pregnancy or it could be multiple pregnancies. That is what we are faced with. So let's face it. Now let me take you through two interesting cases. Now this patient was a 28-year-old female with a 31-year-old husband, severe male factor with ejaculatory dysfunction. The cycles were regular. Ovulation was established in an earlier cycle. ICSI was done, 12 embryos grade A, and a day 3 transfer of 3 embryos done. The cycle failed. Now she came for an FET after 3 months. This was about 5-6 years ago. The children are now 5 years, yes. Now baseline ultrasound showed a shadow in the endometrium. A 3D ultrasound scan revealed an adenoma of 2 centimeters projecting into the endometrial cavity. It seemed to have a broad pedicular base. Now the dilemma was, should we resect it hysteroscopically or just go ahead and do a transfer? So here is the picture of the sonographic picture that he has described. This is the big adenomyosis, which is not jutting into the cavity, and this is the small endometrioma, adenomyoma, which is projecting into the cavity. And this is how it has been shown transversely. There was also a small endometrioma in one of the ovaries. And this is what you see in the picture. You can see over here that the junctional zone is a little distorted over here. It is not absolutely linear as you see in the posterior part. This part is broken. So this was what we got. And we had a beautiful blastocyst. We had 2 blastocysts over there. Now the dilemma is, this is what the picture was. This is the adenomyoma. Should we transfer or should we not transfer? Should we transfer or should we resect it? What are the advantages? What do we find in the literature, first of all? If you have a polyp of this size, suppose you have a polyp, they showed that the pregnancy rate is always better when you do a polypectomy in these patients. Okay, so less than 2 centimeters is the cutoff. So basically this was in 2010, but we also know that the cutoff from the RCOG guidelines is 2.5 centimeters. Some of them say 1.5. But having said that, we know that if there is a polyp of a slightly larger size, it does well if you resect it. And if you, what about an adenoma? What about adenoma? Now, now we know that the endometrial receptivity in endometriosis and adenomyosis is disturbed. There is a dysfunctional endometrium over there. And that is what we saw in this picture when we did the ultrasound. We saw that there was a distortion, there was a broken endometrial zone over there, endomyometrial junction, which in that region was not proper. And the rest of the endometrium was quite fine. So Therefore, and we also know that the impact of adenomyosis on women's fertility is quite dismal, in the sense that most of the studies have concluded that it reduces the implantation and the number of embryos transferred, clinical pregnancy rate, ongoing pregnancy rate in women who are undergoing, and then also it leads to miscarriages. So therefore, we were in a dilemma whether we should actually be resect it, or whether we should continue doing it. So case was discussed with the couple, discussing all the pros and cons, and they decided to take a chance. A detailed informed consent was taken, and Zoladex 3.65 depot was given. And so because she also had that small endometrioma in the ovary, and then this was followed by an endometrial preparation. A single blastocyst transfer was decided. Now, how did we go about doing that? Now, we decided to measure this length and see where this was, because the other larger part was outside, it was not jutting into the endometrium. And in the linear view, as well as in the transverse view, we tried to see where we would go in order to place this embryo. Now, we decided that this part is little dicey, because one, this projection is there, and secondly, the endometrium here could be dysfunctional because of the presence of the adenomyosis in the close to the fundus. So finally, we decided that this length was about 5.9 centimeters. And if you look at the trajectory of this, of the fluid which would be passed when we are transferring the embryo, that would be another 1 centimeter. So a total of 6 centimeters was actually where if we were to go at the place where, we have to plant it. If we were to go there, it would be 6 centimeters. So therefore, we decide to keep it under this here, somewhere here, so that, basically we are not in the region which is looking bad. So what happened is that, 1 minute, I think I've missed one slide. Let me go back and get to that slide. It was important. Sorry for this. Yeah, this one. So when we reviewed the case, the advantage is that if you do a hysteroscopy, you get a clean cavity. The disadvantage is the scarring of the endometrium, which may take a long time, and it wasn't really so big. And this, unfortunately, this adenoma was at the point of maximal implantation. It was just about 2 centimeters below the fundus, and all this region was showing a dysfunctional endometrium. So therefore, we really didn't know whether we are going to do the right thing in putting it in or not putting it. However, after discussing with the patient, we decided to go ahead, and we did this mock transfer. And this was the beautiful one blastocyst that was formed, which was to be transferred. And you can see over here that there was little granulosa cells also that we had attached to it. So on the final day, the ultrasound findings were the same. It had not decreased in size, despite that one Zoladex that we had put in. But because we had done a mock transfer, it was very smooth, and it was done. The transfer was done below the point which was supposed to be bad, and a routine luteal support was given. And then what happened is we found monozygotic twins. Imagine, we were scared of one, and here there was a splitting of the blastocyst, and we found monozygotic twins. So we know that identical twins are very rare, even in IVF. So 3 in 1,000 births have been reported. There is no discovered genetic predisposition. Older mothers have a higher chance of having twins, but this one was young. When the egg hatches out of the shell, it can cause blastocyst to split, and the older the egg, the harder the shell. So here are the twins, and this is what we had got. Now, this is one of the largest studies from Japan. It is talking about the risk factors of zygotic splitting after so many 9 lakh single embryo transfers. It was published in the year 2018 in Human Reproduction. And to our surprise, to my surprise, I found that endometriosis and male factor are the biggest predisposing factors to zygotic splitting and even after a single embryo transfer. So this was interesting because ours was also a blastocyst transfer where a single embryo had been transferred in a patient of endometriosis and severe male factor. So basically, this is something that was quite an eye-opener for me. However, the pregnancy proceeded without any problems, and finally she did deliver twins. Another interesting thing that when you review literature, you find the model of monozygotic twin was first described by Conner in 1955, and it has now become an accepted fact. But it depicts 4 stages of embryological splitting along the timeline of development. At the 2 stage and prior to the compaction of the morula, resulting in dichorionic diamniotic twins. The inner cell mass at the blastocyst stage, which results day 4 to day 8, which is a monochorionic diamniotic twin, and bilaminar embryonic disc in the late blastocyst stage from day 9 to 12, resulting in monochorionic monoamniotic twin, and the primitive, if it is the primitive streak which splits, that is after 13 days, it gives rise to the conjoined twin. So this was actually found by him, described by him in 1955, much before we had IVF. But you can see over here that there is a blastocyst stage splitting which has been described, and even in the late blastocyst. And of course, here we found monochorionic diamniotic twins in this particular. So because it was the inner cell mass probably at the blastocyst stage which had split. So multichorionic pregnancies following single embryo transfer have also been reported from India. And of course, you see that there are several factors which have been shown associated. Like I said, that huge data from Japan showed that it is endometriosis, but micromanipulation of the zona pellucida during ICSI, PGS, and PGT or assisted hatching, although controversial, have been reported to increase the monozygosity in some studies. And of course, like I said, the biggest collection of twinning is basically from the Japanese ART National Registry. And the mechanism which have been hypothesized have been shown in several studies to significantly increase the twinning rate, estimated at 1.7%, which is 4.25 higher than the natural pregnancy rate of 0.4%. So basically, ART itself can cause a slightly higher rate of splitting or after a blastocyst transfer. The proposed theory is that it could be because of the potential hardening of the zona pellucida with extended culture media, causing pinching or splitting of the inner cell mass when it is hatching. And an alternate theory is that extended culture itself may cause changes in cell-to-cell adhesion, and therefore it causes splitting of the internal cell mass. So these are still hypotheses. They need to be looked at more carefully. But yes, there are reasons to think that when you are even doing a single embryo transfer, beware that you may not have a problem ending up in a monozygotic twinning. So this was one interesting case, and I come to the second one now. She's a 34-year-old female with primary infertility and 6 years into marriage with a 37-year-old husband, and they had been trying for pregnancy in the past 3 years with 3 IUI failures, 1 IVF failure, and no record available. Investigations revealed no gross problems. FSH, LH, E2 progesterone normal on day 2, and AMH was 0.8. Ultrasound showed 3 to 4 ARC on each side, and the uterus was normal. So on a day 12, ultrasound scan was decided to look for folliculogenesis, endometrium, and any pathology. We also did a mock transfer. So we had a difficulty in passing the Cook's double catheter cage at Sydney IVF catheter. So a metal sound was finally passed. This could pass easily. Basically, this is what it is. It is not a very good picture. The machine is also old. But anyway, this basically was just to show that a mock transfer was done in this particular patient to see that there is no, because she had had 1 IVF failure also. Now we stimulated this patient with long protocol in view of the poor antral follicle count and low MH. 3 follicles were seen in the right ovary and 2 in the left. Standard OPU was done. 3 M2 and 1 M1 was retrieved. On day 3, A grade 8 cell embryo and 1 poor quality C grade embryo formed. A day 3 transfer was planned. In view of a difficulty in the mock transfer, the same protocol was followed. A Cook's catheter with a stillet was used. However, it could not cross the internal os. Now it was changed to a metal catheter and again tried. It could be negotiated, but unfortunately the inner catheter could not pass through the metal catheter. So we changed again to the Cook's catheter and it passed successfully. Now what happened was that the embryo was placed in the uterus and the catheter was withdrawn. However, when the embryologist inspected the catheter, he said that the embryo was still retained in the catheter, and the catheter tip had blood on the outer catheter. Now there was a dilemma. The embryo is still retained. There had been manipulation, and there is definitely blood on the catheter. So what should we do now? We had three options available to us. Either we return the embryo to the lab, or we defer the transfer, or we retry. Three things we could do. Either we just return it and let it be, or we defer, that means we defer the transfer, or the other thing is that we retry. So what we decided was, let us just, what would be the benefits of delaying an embryo transfer? The advantages are that there could be a natural embryo selection, better assessment of implantation potential of the embryos, a better synchronization between embryo and the uterine environment, and avoidance of multiple pregnancy. We all know that if we are going to transfer a blastocyst, it is definitely going to lead to a better pregnancy rate because of all these factors. So thinking about that, and because we also have, Anisha is working with us, and it is her thesis, which also showed that if you have blood in the outer catheter, it is a little better than having blood in the inner catheter also, because here the pregnancy rate in both the cases is definitely lower as compared to when it is absent. So basically, it does tell us that, somewhere these are the factors which are leading to a failure of fertilization. So this was the embryo, and we let it be, and we did not retry, and we thought we will let it grow to and see what happens on day 5. So it grew to a blastocyst on day 5, and directly the metal catheter was used in order to act as a sound and passed successfully. Now this was changed to a soft Cook's catheter, which was preloaded. This also passed easily, and the embryo was successfully deposited in the uterine cavity. A standard luteal support was given, and a beta HCG of 765 was we got a beta HCG positive after 14 days. Now, the problem is a difficult transfer. The main objective of ET is to deposit the embryos inside the uterine cavity, and it is crucial that this be performed atraumatically in the correct position in order to achieve a proper implantation. Different hypotheses have been said to describe how difficult the ET is and how it may reduce the pregnancy rate. The most important ones being an endometrial lesion or the induction of uterine contractions, which jeopardize the correct embryo placement. So therefore, if you look at the literature, it tells us when sometimes you have to perform additional maneuvers just as we did, so as to pass the embryo into it. And many a times the tenaculum or the valcellum also has to be used. So if you look at this study from 2016 of a difficult embryo transfer, you see that the pregnancy rate, clinical pregnancy rate, when no additional maneuvers are done, is 39.4%. When the outer sheath is basically manipulated, then 36.9%. When you add a stillet, it goes down to 31.7%. And if your tenaculum is applied, it even falls more to 26.1%. Now, this is quite important. And here in this particular patient, we had used everything. And yet, therefore, in the first try, we decided to defer it. Again, from the Indian perspective, this is a very nice systematic review that was published in the Journal of Human Reproductive Sciences in 2018, which tells us that many a times, majority of us are actually having difficulties whenever we are trying to, that means that most of the IVF consultants are facing some kind of a problem whenever they are doing embryo transfers. And in this particular study, in this particular review, they found that 77% had to undergo a cervical dilatation 1 to 3 months before. A Malicot catheter and cervical dilatation had been used in many of these patients as well. And basically Wallace Stillet extra was also used in some of these patients. So essentially it means that the internal loss could not be negotiated in many of them, but of course in 60% of the patients, if there was a problem, there was no problem. But another paper from Dr. Neena Malhotra's unit in 2012 also talks about the same thing and tells us what is the clinical pregnancy rate after a difficult transfer. So you can see over here that easy transfer was performed, although these two groups were unmatched, but still 284 easy transfer, and 58 patients had a difficult transfer. The age were matched, number of oocyte retrieves were also matched, and the number of grade 1 embryos were also near the same. Number of embryos transferred were also the same, but the clinical pregnancy rate over here you can see is 23.6%, and when you have a difficult transfer, it falls down to 17.2%. So therefore, it is important for us to make a correct judgment and to take a correct decision as to whether we can actually transfer this and have a pregnancy or whether we should be deferring it. So again, they also looked at the cycles with bloodless transfers and transfers with blood at the outer catheter or the catheter tip. And again, you can see over here that in a bloodless transfer, the clinical pregnancy rate is 24.1%. In blood on the outer catheter, it is 21.2%. And blood on the catheter tip actually causes a lot of problem and reduces the pregnancy rate to something like 13%, reduced the pregnancy rate to 13.3% in this particular paper, and the number of cycles was quite a large, 342 cycles. So hence you can see over here that the patients, if they have a completely atraumatic bloodless transfer, that is actually the best, and we all know that. But whenever there is a technical difficulty, the question is whether we should be doing it again and again and again, or whether we should be deferring it. That is what is important for us to understand. And when I was trying to do this, when I was reviewing the literature for this, I found an exactly similar case, pregnancy following a difficult transfer. Interestingly, this was exactly the same thing that we had done this was published in May 2002. And I was talking of 2018. So basically, I was just wondering how thoughts, I did not know about this, but the thought was the same: defer it, let it go to blastocyst and then transfer again and see what happens. So basically, thoughts are same, and we know that infertility and IVF have progressed by just practical, the way we try and do our things practically, because basically lots and lots of it is not written in the books. We only decide on what we have done. So with that, thank you very much for being with me today. And just a couple of slides on OPU from the ESHRE guideline. This is not a case. Just that I gathered it after I saw yesterday that I had to speak also on OPU. So these are from the Human Reproduction Open. This is 2019 ESHRE guidelines for basic principle for the OPU. And if I'm not going to read all this, I'm just telling you that you can please note this reference and see this has been given in great details regarding how you should be doing the OPU. What should be the OPU checklist before you start with it? What are the troubleshooting points? Troubleshooting point, what to do when the needle tip is not visualized? What to do when the suction fails? What to do when no oocytes are retrieved? So all these things are written over here, which I think everyone should read. This is very recent, it's 2019. And after OPU also, what should be a checklist? What should we do after that? So that, basically our patients don't get into a problem. And then how should we assess the competence of a IVF specialist? What should be done to see whether this person is proficient enough to conduct an OPU? If you are going to have juniors under you, you need to understand how much they should know. What are the criteria for assessing the proficiency or competency on the technical aspects of OPU? And of course, this depends upon the number of oocytes that they can collect, the number of ovarian punctures that are performed, the ratio of the number of oocytes retrieved to the number of follicles that are aspirated, any complications, and the duration of OPU procedure. So these things are actually going to tell us whether your consultant is good or he's not. So this is something which is going to come in gradually and gradually now that we are having more and more stringent criteria on IVF practices. So this document is something that I thought all of you should read. So I'm just sharing it with you. So with that, thank you very much for being with me today. Thank you very much.
Shalu.
Thank you, ma'am. Thank you for a very elaborate and with so many pictures and with the examples and the literature. I think everybody, all the delegates who've been listening must have got a lot of information how to manage and how to go ahead. Even so many times with adenomyosis, we feel so scared. Should we or should we not? And we keep on doing a lot of manipulations. So I think that's quite a good eye opener that how to manipulate things up, where to do a embryo transfer, especially when adenomyosis, if it is coming and it's not so much encroaching in the cavity, we can go ahead with it. So now we go for the second session. So we invite the chairperson.
Yeah, Shalu, I will come. Thank you, ma'am, for such a brilliant presentation, and you have fully justified the topic. Actually, this is what we were wanting. And for question answer session, ma'am, you have to stay back with us because there are so many questions which you will answer beautifully. And we were really not aware that though the literature says that intrauterine pathology may still be there in 25% cases where there is recurrent implantation failure. So I hand over to Dr. Sonu Balhara for the next session. Over to you, Sonu.
Thank you, ma'am. And over to our next session, I invite Dr. Priya and Dr. Reema. Dr. Priya is our Joint Secretary of the Haryana IFS, and she's a Senior Infertility and IVF Consultant at Cloud9 Hospital, Sector 14. And Dr. Reema, I think we can skip because we are short of time. Dr. Reema is our executive member, and she is a senior IVF specialist and director at Vaishnavi Nursing Home, Gurgaon. Dr. Priya, Dr. Reema?
Yes, ma'am.
Yeah, please continue.
So thank you, ma'am, for the kind introduction. And starting with the session, we have a very interesting topic for the next session, that is the clinical approach to improving the endometrium, evidence-based evaluation on that. And it's my proud privilege to invite the speaker for this topic, Professor Abha Majumdar, ma'am. She is a well-known figure in the field of infertility. We all know she is a stalwart here, and she is a director, Center of IVF and Human Reproduction at Sir Gangaram Hospital, New Delhi. She has received President's Medal for Best Medical Graduate for the year 1970-75. She is responsible for the first IVF baby born in North India in 1991 September. She has received award from DMA on Dr. B.C. Roy's birthday, Outstanding Contribution to Medicine 1999. She has a Lifetime Medical Excellence Award obtained by Hippocrates Foundation 2014. She has received Abdul Kalam Gold Medal 2015, Rashtriya Gaurav Gold Medal Award 2017 by Global Economic Progress and Research Association, and a Distinguished Teacher of Excellence Award for PG Medical Education by ANBI and NBE 2017. Awarded at the Economic Times Healthcare Awards as the Icon of IVF of North India, her team awarded as the Best Integrated National Team of IVF and the Best Coveted Award as the National IVF Champion of the Year 2019. She is the course director for the Postdoctoral Fellowship in Reproductive Medicine by NBE since 2007. Welcome you, ma'am.
So I'm going to speak on clinical approach to improving endometrium in assisted reproductive technology. This is evidence-based evaluation. And again, I would clarify a small thing here that I'm going to speak on endometrial thickness and not recurrent implantation failure, because that becomes a very huge topic. The endometrium is responsible for RIF also. Maybe I just included one last including slide because what my impression was that I only need to speak on endometrial thickness. So my presentation is around that. But when I heard that you also want recurrent IVF failures, I thought I'll include one slide of that also in this. So it is very interesting to know that in 1958, the first ultrasound was started by Ian Donald. It was an obstetric ultrasound, and this was the start of journey when we started seeing things inside our body through sound waves. And later on, TVS was started, and in Germany, Richard Zollner, who was an engineer who worked for Siemens, developed the first real-time scanner. And with this ultrasound, we started seeing the uterus, the endometrium, the myometrium, and on the other hand, with the birth of Louis Brown, we had a lot of insight into reproductive, the area of reproductive medicine. And here the concern for thin endometrium arose for the first time after we had the knowledge of ultrasound as well as of IVF. So the endometrium, can I have this panel a little away? It's just taking away my, okay. The endometrial cycle is
in two phases. The proliferative phase, we all understand, is effect of rising estradiol. What happens here is active proliferation and a lot of vascularization to ensure nutrition and suppression of apoptotic factors. This is all what happens in the proliferative stage or phase. It is the effect of estradiol, and this is what we want in our cycles where we are going to do embryo transfer, that we have this effect to its fullest. Then what happens, the secretory phase and desudilization is the effect of progesterone. Here what happens, proliferation is suppressed, stops proliferation, induction of cell differentiation into stromal and glandular epithelial cells, and vascular remodeling happens. Angiogenesis continues, but it cannot continue the way it was happening in the proliferative phase. In fact, there is coiling of these vessels and intersusception of spiral arteries so that it fits into this endometrium, which is not as thick as it had become in the proliferative phase, and infiltration by large number of immune cells from bone marrow, natural killer cells, T cells, macrophages, everything happens. In fact, the proliferative phase has upregulation of a lot of factors and downregulation of the tumor suppressor gene PTEN. Secretory phase again has upregulation of a lot of factors and downregulation of MUC1 and CSF1. So what is the whole purpose of all this? Of all the proteins, of all the genes, of the progesterone, of the estrogen, the whole purpose of endometrial growth and receptivity is all targeted towards achieving only one ultimate function, which is implantation of embryo. If it doesn't happen, the endometrium sheds off, and again it prepares itself next cycle for implantation of embryo. And implantation of embryo can only take place in a very precise ovarian estrogen progesterone derived phenomena, which creates the window of implantation. This is a self-limited period of endometrial receptivity, which is for about 24 to 48 hours and spans between 19 to 23rd day of a 28-day menstrual cycle. So it doesn't start before 19, doesn't go beyond 24th day. We all know implantation failure happens due to defective seed and defective soil. It is the soil which we are going to talk about. And when we talk about soil, implantation failure has endometrial receptivity defects, embryonic defects, multifactorial reasons, but we will concentrate today on thin endometrium, especially. The thick endometrium is much easier to deal, so we don't need to go into details of that. When do we call an endometrium thin? At the height of proliferative phase in an ovulatory cycle with maximal estrogen exposure. If endometrium is lower than 7 mm and does not show a triple line character, it is generally felt that the endometrium is thin and might interfere in optimal implantation. So the building stone for architecture of proliferative phase is the effect of rising estradiol. It is this phase where you see post-menstrual that the endometrium rises from this small part and it goes up to what you see at ovulation. Building the endometrium for embryo transfer, now we have two ways. How do we build the endometrium for embryo transfer? In a fresh cycle, we don't have to do anything because we've stimulated, the endometrium is also already built, and we do a transfer. It is the frozen embryo cycle where we have to build the endometrium for embryo transfer. So we can, estrogen can reach the endometrium by two sources. One is ovulatory cycles become the source of endogenous estrogen, and non-ovulatory, that is hormone replacement cycles, which give exogenous estrogen. So how do we get ovulatory cycles as source of endogenous estrogen? It is natural cycle. It is the best option for endometrial development in regularly ovulating women. And most of the countries follow a natural cycle FET because it gives the best quality of estrogen which is being produced from the patient's ovary herself. Or we can also give a mild stimulation to cycle with ovulation inducers in oligo-ovulators. And what are these drugs? Well, we can use tamoxifen, clomiphene, letrozole, and gonadotropins. However, gonadotropin is a very good source, a very small dose, good source of endogenous estrogen. Non-ovulatory cycles, what estrogen do we use? Most popular is oral estradiol valeric, gram tablet given as 6 to 8 milligram daily in divided doses. We do not increasing this dose to higher doses because it goes through the liver, and if this dose doesn't work, that means understand that the metabolic clearance of this drug is happening faster than we want it to happen, and therefore the endometrium will not respond to a higher dose given orally. We can add on another source of estradiol gels, which can be given as 2 to 3 applications a day. And this would be absorbed from another source, will not get metabolized in the liver, and so would have added effect with the oral estradiol valerate. Vaginal rings, tablets, and creams are also used in some countries. Well, we don't use it. And its side effect is vaginal irritation. And when we start vaginal progesterone, then the absorption may become erratic. And conjugated estrogens and ethinyl estradiol, these two are not used. They are not appropriate for endometrial development because they are not like natural micronized estrogen. Now, when we start HRT, it is HRT or ovulatory cycle. What is the importance of basal progesterone in a HRT cycle? We do a day 2-3 scan to see that yes, the endometrium is fully shed. The ovaries are sitting quiet, even if they have cysts, but the endometrial thickness is nice and thin. And we like to do a progesterone also then. The detrimental impact of elevated day 2-3 progesterone levels are there not only in COS cycles, which are going in for embryo transfer. It also happens in HRT cycles where we are planning an embryo transfer. But it is still not clear. Data is limited. Elevated basal levels of serum progesterone of more than 5 nanogram, according to this paper published in 2017, does not seem to have a negative impact on reproductive outcome. Remember that we do cancel cycles if progesterone is higher than this, the base, like we do it in COS cycles also if we are planning a fresh transfer, but it may not have such a big negative impact on the reproductive outcome. One thing I wanted to bring to everybody's attention was days of estradiol. Please understand that once HRT, within 12 to 14 days of external estradiol administration, that is valerate or hemisuccinate, whichever you are using, a transvaginal ultrasound is done for assessing endometrial thickness and also confirm that there is no dominant follicle, especially in women who ovulate well and where we may have started estrogen a little late. In some, we find that just 5 to 7 days may suffice for adequate endometrial priming. Earlier studies did show caution is warranted since a higher miscarriage rate has been reported using shorter E2 priming period of less than 10 days. Possibly here, the endometrium was thicker to start with, was quite thick in the COS or controlled ovarian stimulation cycle. So this endometrium is not really the best endometrium for transfer and hence maybe a higher miscarriage rate. On the other hand, estradiol administration may be prolonged for up to 28 days or even 36 days if necessary without compromising reproductive and thus offering a greater flexibility of timing of FET. And this is the second article. You see, blastocyst, does the duration of estradiol treatment influence clinical outcome? This was published in Fertile Sterile in 2019. You can go through it. It's a very nice article. You can, be so flexible with your embryo transfer that holidays, you can skip Sundays, you can skip your absence, and whenever the ET is more than 7 mm, you can continue estrogen for so that on the embryo transfer day everything looks normal and you can do transfer. Progesterone supplementation, once it is commenced, you can't change the timing of FET. So you can sort of change your estrogen administration to as long as 28 to 36 days also without any fear that menstruation will ensue. And if it ensues, then the patient is either not taking the tablet the way you've told her, or somehow her metabolic clearance, hepatic clearance has been so fast her estrogen levels. Now we have to understand thin endometrium. the causes could be congenital. And if you see Mullerian abnormalities, then you will find that generally they have a lower endometrial thickness, a lot of girls. Or if there have been poor exposure to estrogen due to deficiency in the HPO axis, like in hypo women. Acquired, the biggest threat for thin endometrium is dilatation curettage for miscarriages. Damage to bacillus layer may lead to thin endometrium, chronic bacterial infection, STD, PID, and genital tuberculosis. Inflammation and scarring of endometrium happens, and surgical procedures in the uterine cavity, such as hysteroscopy with use of cautery, submucous myomectomy. Sometimes this can also cause damage by scarring and adhesions. And I brought in a very beautiful paper here, published way back in 2008, where they said thin unresponsive endometrium, a possible complication of surgical curettage compromising ART outcome. And here they thought that thin unresponsive endometrium was associated with curettage, not necessarily with intrauterine adhesions. Even if adequate thickening eventually occurred, the reproductive outcome was still very poor. We have to remember that any instrumentation into the uterine cavity, may it be a DNC, miscarriage, we avoid using sharp instruments when we do suction evacuation. We don't like to use a curettage. We use just a plastic cannula for suction. And if you are not sure that you've emptied the cavity, you can use a see that the cavity and all the contents are evacuated. Then the other important, what are the modalities to diagnose these problems? Well, we have ultrasound and we have hysteroscopic assessment. Ultrasound can be 2D, 3D, endometrial volume, Doppler blood flow. As I told you, the development of ultrasound was key to finding what are the problems in endometrium. And number two is the development of hysteroscope. Assessment of Mullerian anomalies can be done, visual demonstration of synechia, fibrosis, endometriosis, distortion, hypertrophy with infection, and then we take appropriate biopsies, do histopathology, cultures, and find our final diagnosis. So what is the aim of, how do we treat? What is the aim of treatment? If we find things, is if we find our offender, and number two is if we don't find our offender. If we find our offender, then like all medical practice, we have two treatment modalities, surgical and medical. Surgical, you can do hysteroscopic corrections. In medical, you might find non-specific endometritis where you can give doxy, erythro, or whatever you fancy to give for 3 weeks. And if there's specific endometritis like Cox, then you will have to start her on anti-tuberculous treatment. If you don't find the offender, you find everything looks normal inside, the endometrium is normal, but it is thin. So what do we aim treatment at? One is improve uterine blood flow to boost endometrial development. And number two, stimulate endometrial cell colony growth. What are the drugs which improve uterine blood flow? Low aspirin, sildenafil, high dose vitamin E, and pentoxifylline. What are the drugs which stimulate endometrial cell colony growth? Is G-CSF, tamoxifen, HCG, given in HRT cycles from day 7 onwards, and stem cell therapy and platelet-rich plasma. So these are the few. I'll just offender not found is very important for us to know, because this treatment is generally empirical. Very little evidence supports any method of treatment. Methods which improve blood flow to boost endometrium are low-dose aspirin, which inhibits release of vasoactive substances, thus prevents and platelet aggregation. And the first reference is for this. Then vaginal sildenafil, which is given in doses of 25 milligram QID, and glycerine skin patches, which produce nitrous oxide in smooth muscle, thus dilatation of the uterine vessels, reference number 2. And third method is pentoxifylline, 400 milligram BD, or high-dose vitamin E, which means 600 to 1000 milligram daily, as anti-fibrolysis, anti-fibrotic treatment. So these methods have been tried by various workers. We've also tried and given them up because of either the side effects, because of no good effect. Then what are the treatment modalities which encourage proliferation, stromal proliferation. Well, GCSF, slow intrauterine perfusion on day of HCG and repeat on day of OCR. The biggest question which surrounds this is, how does GCSF increase endometrial thickness in such a short time of 2 days? HCG has been used RT cycles also, where one gives it from day 8 onwards in doses of 150 units. It modulates endometrial receptivity to IL-1, which triggers angiogenesis and causes major molecular changes essential for implantation. Tamoxifen, it's a new use of an old drug, proliferative action by upregulating Ki67 and in endometrium. Thus, it modulates estradiol biosynthesis and then bone marrow stem cell, endometrial regeneration using autologous adult stem cells in Asherman syndrome, adult bone marrow stem cells. And the last is PRP, which a lot of people are practicing. This is rich in growth factors with anti-inflammatory and mitogenic potentials. It has tissue regeneration, anti-inflammatory, tissue hemostasis, and wound healing factor. So all these, they are injected into the patient's uterus, and we wait and see what happens. Tamoxifen is given orally. Rest all the drugs are. HCG is given as injectable over a period of 10 days or 15 days. Bone marrow stem cells are injected into the uterus. GSF is injected into the uterus, and platelet-rich plasma injected into the uterus. So I want to give you some practical tips of developing the endometrium. Assess endometrial thickness in a natural ovulatory cycle or in the OCR cycle at the ovulation time to know what is the optimum endometrial thickness for that woman. Do not, one shoe doesn't fit all. So your cutoff of 8 mm or 7 mm or 10 mm is not appropriate for everyone. So see what is her endometrial thickness. Make sure basal endometrium and start of HRT is 4 millimeter or less. If you don't reach optimum endometrial thickness in 2 weeks of oral estradiol, add another source of estradiol like dermal estradiol 3 times a day with the same timings of oral E2, so that the patient doesn't have to mess around a lot. You know, morning 7 o'clock, afternoon 3 o'clock, night 11 makes a good 8-hourly cycle. If the ET does not within 1 millimeter of natural ovulatory endometrial thickness, then stop and give progesterone withdrawal. So your reference point should be the endometrium which she reaches during her ovulation, if you think that is normal and there is no intrauterine pathology or synechia or anything else. You can even start with estradiol, dermal and oral from the beginning in these women where oral was not enough and you had to add a dermal source after 2 weeks. And if endometrial thickness reaches 1 millimeter less than the ovulatory endometrium, go transfer, because exogenous estrogens don't fit on the receptor as well as endogenous estrogen. So even though the endometrial thickness is slightly low, it doesn't stop implantation. Give only dermal estradiol 2 applications 2 to 3 times a day for women who have liver problems, who are sensitive to estrogen, or who are not allowed to take oral estrogens due to DVT or something, and assess endometrial thickness after 3 weeks after basal ultrasound. And I've done so many transfers in women who were totally on dermal estradiol very happily. They were on this hormone replacement, just came say within a month, and I saw endometrium was good, gave her progesterone and did a transfer, and it worked wonderfully. You can even do a natural ovulatory cycle embryo transfer in ovulating women. Otherwise, in oligo-ovulatory women, induce ovulation and transfer embryo. And here, low-dose gonadotropins really do very well. And I'm a great proponent of using. In other women with POF, HRT is the only option. But if you give them gonadotropins, human menopausal gonadotropins, sometimes enough endogenous estrogen despite no dominant follicle, and the endometrium grows to 7 or 8. You can start progesterone here and just little oral estradiol of 4 to 6 milligram to make luteal endometrium and transfer. You don't need to give them a high dose estradiol because they've already produced enough estradiol, but since you will stop the injections, so you need to give them some oral estradiol or maybe patches or maybe dermal. Assess the endometrial cavity by a good hysteroscopy, even with a normal 3D ultrasound, if an endometrium continues to be suboptimal for her, especially in women with any history of previous DNC or previous hysteroscopy or delivery also. So remember, a few facts to be remembered about thin endometrium. It does not interfere with implantation if blood flows are favorable and synechia are ruled out. Minimum thickness of 4.2 has also to have established a clinical pregnancy. Very recently, I had a patient where I could not grow the endometrium to more than 4.2, even after doing hysteroscopy, where I found near one ostia, there were slight synechia. I wish I could have put that video here. It was such a beautiful thing. But after that, also her endometrium did not grow to more than 4.5. And I did a, and she's now 6 months pregnant. So please understand that endometrial thickness is a good embryo can overcome endometrial thickness, which is much lower, provided there is no pathology inside it. Bald man, not always a bad man. Now, my take-home message for all of you is hysteroscopy is a must in persistent thin endometrium. Even a virtual hysteroscopy by ultrasound shows a normal cavity. If the offender is found, treat appropriately. All drugs intending to increase blood flow or cause stromal proliferation of endometrial cells may be tried in desperate situations, but with uncertain outcome. Use of PRP is increasing today. We need to do proper studies to validate PRP. Also, we are giving it just for 1 or 2 applications of PRPs. Progesterone start. So I really don't know how well this will work. And development of stem cell therapy may be the only scientific way of regenerating atrophic endometrium. So this is all about endometrium, which is thin. But since RIF was also a point, I'll just bring in 2 things. That endometrial receptivity, there are only 2 things which can increase endometrial receptivity. All these drugs I've described, all the methods I've described, is to increase endometrial thickness. If the thickness, well, you find a good 8 mm triple line and patient is failing to implant, then one method is endometrial injury or scratch, which is endometrial stimulation to cause pseudo-decidual reaction and production of VEGF to help enhance implantation. This is done in unexplained infertility. This is done in IUI cycles. This is done in women with PCOS undergoing ovulation induction, and it is done in IVF 1 cycle prior to the FET. The other test is gene analysis of the window of implantation. Now, normally what happens that the receptors in the embryo come out once the blastocyst starts hatching. And at the same time, the endometrium should have its receptors, the fangs coming out so that both the fangs can fit into each other. Sometimes this does not happen. The embryo's fangs have come out, but the endometrium is or in developing its receptors which come out to hold the embryo. And hence, by the time those receptors come out in the endometrium, the embryo started degenerating. On the other hand, this phenomena can happen before also. That means the embryo is getting the receptors, presenting them outside the surface a day later after the endometrium has already brought out all the receptors and closed them also. And then the embryo gets the receptors on the surface. So such situations can be looked by gene analysis known as ERA, endometrial receptivity array, ERA, which involves assessment of expression, which are either upregulated or downregulated. So these are 2 methods where we can look for this. ERA people have also tried to bring up the microbial environment, the use of antibiotics and probiotics for the same. They've done, apart from ERA, they do 2 more tests, which I don't think have gained much popularity, and hence we do not really recommend. Alice and Emma are the 2 other tests, but ERA is one which a lot of centers do, and even we do when we get true cases of RIF. So I just brought this so that we don't leave the topic just at endometrial thickness. But that is all about it. Thank you very much. Thank you very much.
Thank you, ma'am, for such an elaborate discussion on this enigmatic topic of endometrium. And rightly said, ma'am, at times the endometrium is thin for us, but it is not thin for the patient. So we should be looking upon the natural endometrium of a patient. Ma'am, just one practical tip from your side. What is the best out of all these strategies? What works best in thin endometrium where there is no pathology?
Where there is no pathology, or where
Yes.
there is a pathology. Where there's no pathology, see, I give 2 sources of estrogen. I like to give oral 2 milligram 3 times a day, and I also give the gel 1 pump 3 times a day, or the cream 1 spatula 3 times a day. And I don't care whether I give it for 25 days, 28 days, keep reassuring the patient that nothing will happen. At times I have added, when I had nothing else to offer, I have added vitamin E, and I've added aspirin, but I think they hardly help. So this is all I do. And if nothing helps, then I go for a natural cycle. And it has helped tremendously. With a natural ovulatory cycle needs a lot of monitoring around ovulation. And what I normally do, she's got a 28-30 day cycle. I call her on day 11, 12, do ultrasound for endometrial thickness, do her E2, progesterone, LH, and then tell her you go home. And you do a progesterone on a daily basis for the next 3 days. The moment I know that basal progesterone was less than 1, the moment her progesterone goes over 1, that day I call her back to have the ultrasound. And that endometrium is the best endometrium. And accordingly, because you know that that is the day of progesterone rise, you can treat it as the first day of progesterone replacement. And accordingly, whatever your protocol is, whatever age of your embryo is, you call her on that day, and you can give her a progesterone supplement from here onwards, from the night or next day morning also, because she's already making endogenous progesterone, which is the best progesterone. And you are supplementing from outside also. So she has enough progesterone in that. I sometimes also, when I'm not sure, her progesterone has gone 1.1 from 0.6. So I tell her, okay, have it tomorrow also. It's just this that she needs 3 days of continuous blood test. Sometimes I also add a LH with that. And it's so nice. LH is 50 or 54 one day before the progesterone has risen. And next day the progesterone has risen. You can do 1 more progesterone, and from 1.1, if it jumps to somewhere between 2 and 3, then you know this is her endogenous progesterone, which is coming up. You can supplement a little bit and do embryo transfer accordingly. We give 5.5 days for a blastocyst, and we give 3.5 days for a day 3 embryo. So either it's 5.5 days for a blastocyst, half days for a day 3 embryo.
Thank you, ma'am, for the most precise and evidence-based presentation. Most of our questions are answered, though we will have some queries in the end. And now we have with us Dr. K.D. Nair sir has joined. He is our president-elect for 2022. And I will request Dr. Pooja Sinha, our bright young bachu from Rohtak, to introduce Dr. K.D. Nair sir. Over to you, Pooja. See, I had to get your photo from Facebook, Pooja. This is what I could get. If Meenakshi is not joining us today, we have only Pooja. Pooja.
I have the honor to introduce Dr. Nair sir. He's our president-elect of Indian Fertility Society. He's a senior consultant and HOD of Akanksha IVF Center at Mata Chanan Devi Hospital, New Delhi. He's also the convener of the Education Committee. So, yeah, of IFS from 2018 to 2022. And he's also been the chairman of the Infertility Committee of AOGD. So, we'd love to hear you speak.
Over to you, sir.
Over to you, sir.
Ma'am. It is my pleasure to be here in the Haryana chapter of IFS in the webinar. Dr. Seema called me and she wanted me to speak on the better IVF outcome following improved lab ambience. So I wanted to be very sure with her that she wants me to speak on lab ambience. She doesn't want me to speak on enhancer. I think enhancer has already been partially covered by the other speakers. So my topic is better IVF outcome following the improved lab ambience. Human reproduction has become a major health problem, and humans are the most infertile of all mammals. This is very surprising. 15% of the couples are infertile, and almost 50% are due to the male factor. The reproduction has now shifted from the story of birds and bees to inside the lab. You see, now you can have sex for fun, and for reproduction there is ART. That is the problem, that people are not focusing on reproduction as a essential process. They say for reproduction, who can go have ART to help us. We all know the first IVF baby born in July 1978, Louise Brown. And the thing which is holding her hand, this is desiccator. That was the type of incubator, so-called incubator, which was being used that time. Now we have come a long way from that time frame to the present one, but the basic concept of IVF has still remained the same. Normal ovarian stimulation, sperm collection, fertilization, culture in the lab, followed by embryo replacement. But what has changed is the success rate. Initially, it was around 10%. Now it has come down to 30 to 40%. And what has increased is the number of happy couples. All this is because of advances in the technology and the trends of ART. The outcome of IVF currently in a patient less than 35, clinical pregnancy rate is almost 45 to 50%. The miscarriage rate is 50 to 20%. Live birth rate per IVF cycle is 30 to 35%. And cumulative live birth rate is around 65 to 75% over a period of 5 to 6 cycles. That is the current outcome in IVF currently. The success depends on so many factors: patient, both husband and wife, lab, procedure of IRT, post-ART medication. The troubles can be twofold: either it is clinical parameters or in the lab parameter. My topic is about the lab ambience, whether improved lab ambience give us a better success rate. So the parameter of success do you have in you? The key of setting up a good lab is to think like an embryo. That is very important. This has been told when I was taking my training abroad, that if you want to set up a good lab, you have to think like an embryo. What is an embryo think? You should have eagle eyes, lady's finger, lion heart. You should be very gentle soul and heart which beats for the patient. That is important. Your heart should beat for the patient, you see. Everything is important. When you're thinking of setting up a lab with good ambience, what do you want to do? You should think of location, think of equipment, think of the personnel, think of air quality, think of culture media, and think of the emergency plan. All are the issues you must consider when you're trying to set up a lab with a good ambience. Location is one of the most important. You can always buy better equipment or replace them anytime, but you cannot change your building easily. You cannot shift from one building to other building because you don't like the previous one. No, you cannot do it. The air quality index of Delhi, the capital territory of India, according to WHO survey, among 1650 world cities, it is the worst of any major city in the world. That is the poor air quality we are living in Delhi. This is how the picture looks like. The picture of New York, very clean. The picture of Delhi, it is all covered with haze. That is the early morning picture. So we have presented one paper in ASHRAE in 2020 about the quality of embryo development in in vitro fertilization lab when the atmospheric air quality index was above 500, that was hazardous. This thing has happened in the month of October to December 2019. This thing happened in Delhi. And if you look at this, our fertilization rate, the clinical pregnancy rate, and implantation rate, all the parameters went down when the air quality index was above 500. So air quality is very important factor for the improvement of the success of any IVF cycle. The location of lab, it has to be away from traffic, from construction area. It should be preferably on the first floor, and it should be devoid of vibration. They should not be in the basement area, should be away from polluted area. Location adjacent to parking lot, gasoline station should be avoided. And anesthetic gas used in oocyte retrieval may linger in the air, so you should have suitable extraction system. Location of storage area and equipment like incubators, centrifuge, and cryo equipment should be logically planned. You have to plan this lab. Separate office space for administrative work, record keeping, data entry, general wet area, washing of equipment, sterilization should be separate from the embryo laboratory. And if fixities are applied, analysis should be performed in a separate room in a fume hood. When you are trying to make a lab, you should have a proper bench height, adjustable chair, microscopic height, efficient use of space and surfaces. All these are very important issues when you are setting up a lab. And what should be the minimum area? It should be around 1,000 to 1,500 square foot, depending on the number of cycles. If you are having more number of cycles, you need definitely bigger area. And you should have separate area for identification, for micro manipulation, for cryopreservation. Gamete handling should be sterile area. The building material used should be inert. You should have a clean room. Tile can be used, and you can have the floor with a seamless vinyl sheet. This is what we are using in our lab in Akansha. And the walls can be having a painted with epoxy paint, 4 millimeter thin. It can be used because the epoxy paint does not give you VOCs. The door should be sealed, lockable. There is no need for window in IVF lab. If present, it should be sealed. Fixative, adhesive paint which release VOCs should be avoided. Steel is a material of choice for furniture and cabinet. That is what we have in our lab there. There is no wooden furniture, is strictly prohibited. You don't have anything from wood. When we started the IVF center 20 years back, we had few table which were used for having the XC machine and all those things. Even we had replaced them. There's all now only steel is being used inside the IVF lab. The component lab has to be non-sterile zone and the sterile zone. The non-sterile zone has the administrative office, a semen collection, and doctor's room. The sterile zone will have a main lab, OT complex, and changing and washing room. This is a representative diagram of how the IVF center can be planned with reception room, the IVF lab, the OT, the scrub room, everything is all interconnected. IVF lab, the equipment essential are CO2 incubator, micromanipulator, oocyte suction, block warmer, centrifuge. The desirable are laser, CO2 analyzer, thermometer, low oxygen incubator, and experimental are like time lapse or MC. Think economically, think of economics, but don't do economically. The average cost of essential equipment in an IVF lab is around 1 lakh. Average cost of equipment for an IVF fixie is about 1 crore, and other infrastructure can cost you another 50 to 60 lakh. What is ideal? What is feasible? What is viable? These are all, when you are setting up a lab, you have to think of what is ideal, what is feasible, and what is viable. This was a IVF lab, say 20 years back, a small room, everything scattered in the room. You have the micro manipulator, you have the laminar flow, you have the oxygen cylinder, all cramped up in a single room. That used to be lab about 20 years back. Now you have a lab, something like this, very nicely arranged, the CO2 incubators, the laminar flow with stereo zoom, another laminar flow with the XC machine, the benchtop incubator. So everything is nicely arranged, you see, lean and absolutely superb this thing, location of the lab. This is another view of the lab that embryology keenly separately working on a XC machine, and you have the other benchtop incubator on the other sides. So you can plan a lab like this, which can help you in improving the success rate. The air quality, I mentioned, air quality is the most important factor. And this was published in 2010 by Legaro. He said the effect of air quality, the nitrous oxide consistently associated with lower birth rate, ozone, decreased odds of live birth rate, fine particulate matter, decreased conception rate. All these are decreasing the success rate. The air quality, the chemical air contaminant are believed to exert a range of effects from fertilization failure to delayed embryonic development, and these effects may or may not be evident morphologically. What is the air quality requirement in ART lab? We should have a high fresh air changes, 15 to 20 air changes per hour, positive pressure, HEPA filtration, chemical air processing using activated carbon and potassium permanganate, and active filtration unit. All this is needed in a good IVF lab. And you should have a CODA tower in your lab, and you should always measure the air quality. You should always keep on checking what is the air quality of the lab. Air quality management is very important, and monitoring of enumeration of particles and microorganisms is what is we check in our air quality index. And the measurement of airflow, pressure difference, temperature, humidity, as well as measuring VOC is recommended. Volatile organic compounds are natural or synthetic chemicals that can vaporize under normal atmospheric condition. And laminar hood equipped with HEPA filter, CODA tower are a must in a IVF lab. Cleaning of IVF lab at least twice daily. Alcohol-based detergent should not be used. Lab personnel should avoid use of perfume, nail polish, and lipstick. The CARO consensus on the IVF laboratory environment and air quality, they had established 50 consensus points regarding the site suitability, design for new construction, laboratory commissioning, and organic and ongoing VOCs management. How to manage the VOCs. The assessing the site suitability, the careful attention should be paid to location of building where an IVF lab is to be constructed. The basic design criteria, you have to use construction material, electric gas conduit, fire suppression, and noxious and corrosive chemicals. The laboratory commissioning and ongoing VOC management, you have to do a burning, deep clean servicing, infection control. What is the CARO consensus? You should have a particulates less than 0.5 micron to 10 micron per cubic meter. You should have less than 10 colony forming units per cubic meter or less than 2 spores per cubic meter in the lab. VOC, total VOC should be less than 500 microgram per square meter. Air changes, 15 total air changes per hour, including 3 fresh air changes per hour. And the ideally overpressure target is 38 to 50 Pascal in the IVF lab. Recommended is minimum 30 Pascal. So this can be attained through a cascade of overpressure across several rooms. It is passing from one room to other room, but ultimately in the lab itself should be at least 30 Pascal positive pressure. There are various products which are used in home and work, which can possibly generate VOCs, like you have petroleum distillate like paint, thinners, oil-based paint. You have nail polishes and nail polish remover, cologne, hairspray. You have dry clean clothes, stain remover. You have adhesive like PVC, cement, contact cement, refrigerator, air fresheners, furnitures. All these products can always generate a lot of VOCs. And your lab should not have more than 500 microgram per cubic meter. The quality control procedure, you should have detailed standard operating procedures. Ensure that all procedures in labs are being done in a uniform manner. A well-written standard operating procedure is mandatory. Every lab should determine its own key performance indicator and the critical level at the end of the day. Internal quality control and external quality assurance program should be run. The standard operating protocol is to assure reproducibility and competence, and these should be constantly reviewed and revised annually. How to maintain the record? You can have both electronic and written, and it has to be reviewed periodically. Why to use the records? To calculate the key performance indicator, and it should be crucial for quality control. This is important for key performance indicator and for the quality control. The quality control is a validated and written procedure for all the procedure, assuring all the media, reagent, disposables are tested, and maintaining and calibrating the equipment regularly. Quality assurance is a third-party thing where it is the quality control is a subset of quality assurance. Quality assurance is done by third-party people, and quality control is the quality to control the quality of product, methods, equipment, environment, so that the lab is working correctly. This is basically done by the in-house team. The quality practice is again equipment maintenance, analysis of result, execution of procedures. We had a Vienna consensus on the development of ART laboratory performance indicators. There are various indicators. Reference indicator is proportion of oocyte recovered and proportion of M2 oocytes at the time of ICSI. We have performance indicators like sperm motility, the 1 PN rate, 2 PN rate, good blastocyst rate. These are all performance indicators. The key performance indicators are IVF, the normal fertilization rate should be 75%. The day 3 embryo development rate should be around more than 70%. The implantation rate at cleavage stage should be 35%. At the blastocyst stage should be 40%. So we have the set key performance indicator, and your lab should try to match as near to this benchmark as possible. The all potent male, 50% of infertility are because of the male factor, and there is deteriorating sperm count and quality is happening in the current scenario. What we have a problem is a semen connection room in the lab. When you have IVF center, you should have a proper semen collection room. It should be excluded from the busy part of the building, should have a clean bed, vibrator, audio-visual, and a bath station. The room should have windows to pass semen sample to the IUI lab, and for confidentiality, the window should be made that the conversation is not overheard. The toilet should not be used for any other purpose. This is how the semen collection room should look like. Most of the IVF centers are using a washroom as a semen collection room. No, that does not help us when we want to collect the semen. And husband is unable to produce semen on the day of pickup, you are in a soup. Hesitancy in the hospital setup, rule out any erectile dysfunction with the history. Ideally, all couples should have a frozen semen sample as a backup. And if patient is still unable to give a semen sample, you have to reassure her. You can use sildenafil, you can ask for a home collection, or you can use penile vibratory stimulation. If nothing helps, you can have electroejaculator also can be used. The newer method for sperm, once you have obtained the sperm semen sample, you have many new methods available for sperm sorting in the IVF treatment. All these are new methods: MAC, magnetic activated cell sorting, microfluidic, PIXI, IMSI. I'm not going to detail of this because this is not part of my talk, but I just mentioned it because these are all the new methods which can also be part of an improved lab ambience. We have presented a paper poster in ASHRAE 2019 on the outcome of sperm selected by microfluidic. If you look at the graph, whenever you use microfluidic, the day 3 grade A embryo, the clinical pregnancy rate all went up when we are using microfluidic, because in a high DNA fragmentation sample, microfluidic help a lot. Similarly, we presented another poster in ASHRAE 2020 that we use laser hatching for a day 5 embryo, and we find that the implantation rate and clinical pregnancy rate went up when we use only quarter of this thinning of the zona, and that helps us in increasing the implantation rate and clinical pregnancy rate. How to maximize the outcome? There is a mushrooming of IVF center. When I started my IVF center, I was 7th IVF center in Delhi. Now there are more than 100 IVF centers in Delhi NCR. So you have to do a SWOT analysis of IVF center. What is the strength? What is the opportunity? What is the threat? The strengths are the motivation, the dreams, the teamwork, the finances. The weaknesses are inability to cope with the failure, lack of risk, lack of training, lack of finances. Opportunity is a new field, rapid growth, quick money, relative lack of competition. Threats are the competition, negative propaganda, PR reason failing you, and natural calamities. Building up a laboratory culture, the most important goal is involve everyone, listen to everyone, show that you listen and act accordingly. So you have to involve everyone, listen to everyone, and show that you are listening to them. Take home message. Do you have in it you? You have to have responsibility. Somebody is watching you. Always think there is God upstairs. moral policing, social responsibility, share the knowledge what you have, if possible, have spiritual bent of mind, be humble when you succeed. Finally, remember, patient is a team member or a shareholder. You don't treat patient like experimental. Patient is a team member for you. And because he's a shareholder, that is why you are existing, and that is why you're thinking of making a lab of a good ambience. Thank you very much.
Thank you, sir, for the excellent presentation. And I will request all our audience to stay with us because we are going to have most important part of this webinar, that is interaction with all our experts. And before that, we have a small trade meet with the Jagsonpal, who have been kind enough to sponsor this webinar for us. So over to you, Deepika ji.
Yes, ma'am. Thank you.
Thank you, ma'am. Good evening to all esteemed faculty and attending doctors. A very happy and safe new year to all. From Naari division of Jagsonpal, I'm Vijay Kumar, General Sales Manager and North, and we look forward to your support for PRORETRO, for luteal phase support in ART, recurrent pregnancy loss, and threatened abortion. We are immensely happy to share with you that after years of indigenous R&D, Jagsonpal Pharma is manufacturing the API of micronized dydrogesterone, which is used in PRORETRO 10 mg tablet, making India Atmanirbhar. For this critical API, thus reducing the cost to the patient remarkably, cost just to be kept 50 rupees per tablet. The efficacy and safety of PRORETRO is assured by BioCleanse study results. A new brand emerges from Naari division of Jagsonpal, PRORETRO. We seek your support for Made in India PRORETRO micronized dydrogesterone 10 mg tablet, assisting motherhood, delivering happiness. For medical management of suspected and confirmed cases of endometriosis and endometriosis associated with pelvic pain, we present ENDOREG, dienogest 2 mg tablet. For the management of fibroids, we present FIBRISTONE 25 mg, mifepristone 25 mg. And we look forward to your presence in our next webinar this Friday, that is 21st Jan at 4:30 p.m. onwards. Please note down the webinar ID and register now. Thank you.
Thank you, Deepika ji. And now we have most important question answer session with us, and we have experts to answer. Very thankful to Abha ma'am, Sonia ma'am, Dr. Sonu Balhara, K.D. Nair sir, Dipankar sir, if he's joined, Dr. Dipankar Banerjee. We have certain queries. There are queries from audience also, and we start with our question. So we take this question from Parul Jaiswal. Some patients develop recurrent polyps with HRT, FET. How to deal? Abha ma'am, you can answer this question.
Yeah, I think these patients have a tendency towards a thick endometrium, and it is generally not polyps, it is thick endometrium which comes back again and again. So they need to be treated with a progestational agent maybe for 2 to 3 cycles before you can take them for HRT. They have a hyper responsiveness to estrogen. So they sort of grow the endometrium faster, and hence be careful that you don't give them a very high dose. Make sure the basal endometrium is normal. A lot of times you don't see the polyp when you do a basal ultrasound, but you see them later on as the endometrium develops. So make sure that you've regressed the endometrium well with a progestational agent like norethistron given for 2 to 3 cycles, and then take them for a HRT PT cycle.
I know you are so much against DNC. Every time you say so much against, but for such patients, is there any advantage in doing a histopathology before procedure?
Yeah, very important. If the endometrium is thick, especially if it is more than 7 millimeter, I think a hysteroscopy DNC is very, very important. I don't say I'm against a DNC.
Right.
I absolutely am not against a DNC for a hyperplastic endometrium. You need to find out, and if one day we miss hyperplasia with atypia, we will regret it later. So it's very important to do a histopathological analysis and then go forward. Yeah.
For such cases, we like to do DNC. That's why I thought
DNC, hysteroscopy, both.
Right,
the endometrium is 7 mm or more, then don't go for direct treatment with progestational agent. First, do a sampling, make sure that she doesn't have any complex hyperplasia or atypical hyperplasia.
Right.
Abha ma'am, there's another question that do you have any different regimen for preparation, endometrial preparation in adenomyosis or endometriotic patients?
Right. You know what, you can give them a long GnRH agonist depot. And when you're doing a FET, especially for adenomyosis, I have done it for some, you give it for good 5-6 months if you've already have their embryos cryopreserved with you. And then you start with long GnRH agonist, and you'll see the adenomyoma shrink a little bit. The receptivity becomes better with the adenomyoma shrinking a little bit. And then you can give HRT for these women in the cycle when you think, I mean, they may not have their periods. They may have complete amenorrhea for 4-5 months. But once the endometrium is less than 4 millimeter, adenomyoma has regressed even 25%. This is the time when you can go ahead and do a transfer for them.
So, ma'am, for estrogen dose will be higher for these patients when we are preparing?
It depends how she responds. If she responds, the starting dose can be 2 milligrams 3 times a day. And after 2 weeks, you can add a gel if you find that there is hypo response of the endometrium.
And ma'am, we don't get that clear triple layer endometrium in these patients.
It doesn't matter, you know, everywhere you don't get a triple layer. Homogeneous endometrium is also associated with implantation, though less than that of triple layer. So don't disregard an endometrium even if it looks homogeneous, because a lot of papers were published in the earlier days where they said triple layered endometrium gives a higher pregnancy rate, homogeneous gives lower, but both give pregnancies. तो जिसमें मिल ही नहीं रहा है उसको तुम रिजेक्ट तो कर ही नहीं सकते हो ना, कि बनता ही नहीं है ट्रिपल लेयर, क्या करोगे?
And they give pregnancy local estrogen in these patients or oral also in these adenomyosis or endometriosis?
You can give whichever. I believe that increasing oral dose, which I used to do earlier, does not help.
Yeah.
You bring it to 12 milligrams or more than that, it doesn't help, because probably the metabolism is such that it just doesn't reach the endometrium. So it is much better to give a different source like dermal estrogen, whether you give the gel or the cream, whichever you want to give. That is absorbed from the skin, goes through the lymphatics into the bloodstream, doesn't go to the liver.
Yeah.
So
after
it has better action on endometrium.
Yeah, you don't give
I give 1 TDS tablet and 1 TDS application of whichever local estrogen you want to use.
So after 5-6 months of depot, you don't give depot, you directly give the HRT. In these
HRT. Yeah. I don't have to induce menstruation because endometrium is already going to be very thin.
Yeah. Thank you.
We can have the questions now, Deepika ji. We can start. I think we will be covering most of our queries. And if any questions left, Dr. Sonu can take in the end. So, ma'am, I can't see this thing. Okay. What is the percentage of, ma'am, this is for Abha ma'am and KD Nair sir and everybody. What is the percentage of RIF cases that you get at your center, ma'am?
I think 2 to 3% in my cases where the endometrium looks good, the endometrium was very good, and twice it happens that 2 blastocysts fail to implant. Then I would say that yes, this is RIF, and maybe 2 cases or 3 cases in 100 cases.
Sonia ma'am, what is your statistics on RIF at your center?
The problem is that we are getting, all of us are getting too many referrals, you know.
Right.
We are getting so many patients from other centers where where it has failed. Now, if you go by the definition of RIF, where you have put in very good embryos and all that, then yes, like Abba says, it won't be too much. It won't be more than 5% maybe. But if you go by the definition of just an IVF failure, then
yeah, agreed, Sonia. IVF failure is very, very common.
That's what I'm saying.
40% maybe.
More than that, even majority of the patients are IVF failures. But if you go by the standard definition, like what she's saying is correct, very few patients. Yeah.
Right. So, KD sir, what is your experience?
We have about 5%.
5. I also have about 5.
Dr. Sonu, your Artemis?
That is almost the same, but we have very few referrals. I think ma'am and all, they do most of the patients who go from us.
No, it's not like
cases are done by them. So 40% like ma'am said, so that's convincing.
That is IVF failure. That's IVF failure.
Yes, I got your point.
But like Abba ma'am said, there was a patient and I was really happy. She had just endometrium of 4 and she conceived because
4.2, you know, and this, yes, I remember her name is Nandita Sharma Puri. Suddenly I remembered her name. And she was getting her ultrasounds done from Chandigarh, from the Milan IVF center, the girl over there, the Sikh girl who's there, she was doing, and when she saw her embryo, she said, I can't believe that aapne transfer bhi kar diya isme aur ye pregnant bhi ho gayi. So, you know, I did a hysteroscopy, and she had a history of delivery or preterm delivery in US earlier, and no history of any instrumentation. I told her, ask your gynae whether there was a retained placenta, did they do a manual removal or a suction, nothing.
But ma'am, I had the same patient, so she had abruptio and
abruptio is
yes.
Yeah.
So just 4 millimeter, and she conceived in the first attempt. But 1 year I waited that maybe the endometrium will grow or something. But
नहीं grow किया, आपने डाल दिया और वो pregnant हो गई.
But ma'am, we need to tell the obstetrician when these patients, if we are not delivering them, that there may be chances of PIH and placenta accreta or the accreta in these patients.
Yes, you are right. Accreta could be there. This is important. But you know what? For this patient, I put in a hysteroscope, and I wish I could have found that video and put it here. There was just a small, the ostia looked a little deeper on one side, and there was a little depression. And I just cut, and the whole new fundus came up. But despite that, the endometrium, and she had very limited time, did not go more than 4.5. Desperately, I gave her PRP, which I don't trust in. Still, the endometrium remained the same.
Ma'am, it's the magic touch that you have makes all the difference. Actually, in literature, very, very rare.
To make ourselves happy. This was a patient's luck, and probably a fact to say that thin endometrium without any pathology does implant, and a good embryo can compensate for a low endometrium.
These are rare of the rarest cases, ma'am, and they need experts.
A lot of cases. There is another girl very recently, Harmanpreet, whose endometrium would not grow over 5.5, and she went on cancelling cycles. I won't name the center where. Then she came to me, got her embryos transferred. Again, her endometrium wouldn't grow more than that. Even after hysteroscopy, found nothing. I reassured her and did a transfer. And she got pregnant with the same embryos which were brought from outside. We didn't make her embryos.
Dr.
Dipankar, one has to plunge into it. If you have 3-4 good embryos, take a chance and implant if you've done a hysteroscopy very satisfactorily and you know that there's nothing.
So, ma'am, you don't believe in PRP. I just wanted to ask you one more thing in this.
I don't, but you know, like desperate karta kya na karta wala. I thought, isko jana hai, kya kare, isko aur ek cycle wait nahi kara sakte. Maine dala PRP and she did get pregnant. So I give the credit to maybe PRP, but I don't use it in my routine practice. Maybe I've used it for 2 patients altogether. After her, I used it for 1 more girl also.
The chances of chemical pregnancy is also high in patients with thin
Yes,
endometrium.
I was going to say that all patients are not going to go up to term. No? They may become pregnant, but they will not progress to full-term pregnancy. There are very few patients who would progress to full-term pregnancy. That is, the pregnancy loss is very high.
Ma'am, what is your view about stem cell and what you're practicing?
I wish we had stem cells, Neeru. We don't have stem cells. Bone marrow से stem cell एक ही paper publish हुआ है नागोरी चैतन्य का.
नहीं सुनीता तेंदुलवाड़कर का भी हुआ है.
अच्छा.
Live birth health का.
हाँ, नागोरी का first paper था शायद.
Maybe next comes from us, ma'am. Haryana.
गुजरात का भी है ना मैम, गुजरात में that doctor.
कोई नागोरी है ना गुजरात वाला तो.
Next question can we have? Okay. So what is the commonest factor, ma'am? Out of all, which factor is commonest for this?
Embryo. Okay. Most important factor is embryo.
Embryo.
Yeah, definitely.
I think from embryo we can see, we can know whether embryo is good quality or poor morphology. But endometrium is an issue which we are having indirect perception, thickness only.
So if we talk of embryo, then
let me just inform all of you, we have lately acquired that AI, artificial intelligence program. Nova has acquired, so that we are using that since October. And Dr. KD, you're saying good embryos, many of these good embryos are not bad.
Yeah.
Not good. Their viability score is so little, it may be 0.5, it may be 1. You find such beautiful blastocysts over there, and when you do their viability score and when you do their genetic scoring, it's very, very poor. So it does explain that embryos are actually not very good, and you know that because we've all been saying 55% embryos, 45% endometrium. There's a crosstalk, no? but I don't know. It's very, very poor quality embryo that we are getting. It's working well, this new method.
See, the IVF failures, it is the embryo quality which is most often responsible. And
of course,
for implantation failure, it could be embryo as well as endometrium, as well as surrounding factors.
Correct.
Right.
Dr. Sonia Malik ma'am, since Levotic catheter is not available, so in long cavity, which catheter you are using and which metallic catheter you are using in difficult cases? So please share your.
Actually, I am using the Cook's catheter only for whatever I do that. Even for the long one, you just have to take it farther. The inner catheter has to be taken farther, and it will definitely reach where you want it to reach.
Very few pregnancies are reported in endometrial cavity more than 10 centimeters.
Yeah, it is not. As it is adenomyotic, so you won't get it.
Dr. Abha ma'am, you are also using Cook also?
Yeah, only Cooks.
Only. And metallic difficult cases, which metallic catheter you are using?
Metal catheter was an old IUI catheter which I'm using, which I picked up in one of the conferences in Bombay, but that is serving its purpose, and we got many more made like that. 3 or 4. Just actually, I saw Dr. Usha Kothari doing all her embryo transfers with the metal catheter. She would first put in a metal catheter and then these were those days when we did not have Cook and all, no? Only Wallace was available, and then we had that very bad Friedman's catheter, which was very stiff. So she had a metal catheter, and she would always thread it first with the metal catheter and then put in the inner catheter, because she was doing her own embryology. She was doing her own embryology also. So therefore, so I have started using the metal catheter in difficult cases. Yes.
Next question, can we have?
We have some questions in the question.
We will take up, Dr. Niru, those questions we will take up in the end. We just finished the questionnaire that we have prepared. Then Dr. Sonu will take up all the questions of the audience. Okay. So ma'am, your choice of estrogen remains estrogen valerate, or we can have other salt also?
Estrogens also. Valerate is one which is internationally approved, but there are other estrogens which have come up in our Indian scenario, hemisuccinate and hemihydrate or something. So all these, I think they are all micronized.
Okay, sir. KD Nair, sir, Sonia ma'am, you want to add anything to it, Dr. Sonu?
You see, if you are giving estrogen valerate and adenovirtum not growing, you can shift to the other product. See, it does happen. Like Dr. say, you can even shift to dermal. Even the oral also, you can shift to other one, and you can find a response.
Important, right, sir? Thank you, sir. Next question. Yes, this is a question from audience also, because ma'am had talked a little about the how we place the catheter. It should be 2 centimeters below the fundus. That question will also come. So ma'am, there has been lots of discussion going on that there are ways to reduce uterine contractions during embryo transfer, because that is another cause of failure. So are you using it in your practice, and what are the...
Yes. I am using it, but I'm not using that very expensive atisoban. I don't use that.
That is from the audience. There is question. Yeah. So ma'am, what are you using? What will you, Pyroxicam or any other thing?
Pyroxicam is what we are using. Pyroxicam.
What is the dose? And
just a one sublingual tablet we are giving.
For transfer. How much time before transfer, ma'am?
20 minutes before that.
20 minutes. And that helps, because it has been reported to improve the results also, implantation rate also. That is what we were reading in the literature. Abha, ma'am?
If you find a person having too much of contraction, probably your progesterone is not correct. That is something that you have to keep in mind always, that maybe your progesterone is not good.
We do her serum progesterone, ma'am? Sure. We do her serum progesterone, or how do we make out then?
We should be doing her serum progesterone, but again, that is another controversy.
Yes, we don't do it normally.
And in many of these patients, you can see the actual contraction taking place. You can see it,
Seema, there is a lot, what Sonia is saying is correct. A lot is coming out on the progesterone. Same route, same dose may present differently in different patients.
Right, ma'am.
And then we use most of it is vaginal progesterone. It may not reflect what reaches the uterus in serum levels, yet a serum progesterone is what is evaluated. And a lot of papers have come out to say that serum progesterone on the day of embryo transfer, if less than a particular value, like 7.5 or 8.5 or 9, will lead to lower pregnancy rates. But on the other hand, because the study is on in our center, live birth has happened with a serum progesterone on the day of transfer of 2.5 also, and it has not happened with 40 also. So, you know, these are cross-sectional studies. And now when I was making this presentation, I didn't bring the progesterone part inside, but there were few slides which I made for progesterone where they are saying that now individualized transfer would be done on progesterone levels also, where one day before you are warming and thawing your embryos, you do a serum progesterone, and if you find that it is low, then you add some progesterone for her and then do the transfer.
You are not giving
इंजेक्टेबल और क्या दोगे, इंजेक्टेबल ही दे सकते हो ना, जिसका सीरम को अगर देख रहे हैं तो उसी से बढ़ेगा. बट आई डोंट नो हाउ मच इट्स logical, because vaginal progesterone may be much higher at the uterine level, and yet it may reflect very low levels in the serum level. So there is a lot of individualized ET being planned on progesterone levels also these days.
You are not recommending anything like Buscopan, relaxant,
No, we don't.
Placement of catheter, ma'am, it is again a little controversial for us, like 1 centimeter below the fundus or 2 centimeter. When we talk of failures, then so what is the ideal that you're following, or it's just ultrasound guided and we know this is the right placement and do it?
Yes, just ultrasound guided, just ultrasound. Although it is written in the book that the point of maximum implantation is 2.5 centimeters below the fundus, but it's very difficult to follow that, you know, when you're doing a transfer. You just have to go in and see that the outer catheter is just cross the internal os, and then you take the internal catheter forward and then place the embryo. Generally, this is how everybody is doing it. But if you are going to demonstrate it to your students, and if you want to show them that this is how it should be done, then yes, you can measure it and put it inside when you're doing a mock transfer. So you would know, just as I showed you in that case, we were, you know, trying to do and place the catheter exactly where we wanted it to. There you have to measure it and then do it. Otherwise, there's no need.
It was the beautiful case which you explained, and we were really happy that you had twins, not even.
Yeah, that is, those children are living here in Vasantvihaar only, and I see them grow. I've seen them growing. They're now 5 years. It was such a pleasure to, you know, have a positive pregnancy after that case.
Ma'am, I just wanted to ask you that, are you using HCG in poor endometrium? Because then this question becomes very relevant, that we are pushing HCG and then we are pushing the embryo. So ma'am, are you using HCG? Any of you, K.D. Nair sir, ma'am, or Sonia ma'am?
One of my fellows did do a study, and I think we found no difference. Sabina did a study.
What I didn't hear you.
Ma'am, putting HCG before transfer in poor, recurrent failure cases.
Yes, we are doing it. We are doing it.
And it is helpful, ma'am.
We are getting positive results.
How do you give it, ma'am? What is the protocol you follow? Like?
There is a paper by this Dr. Modi. If you know of him, he is basically in Mumbai in this ICMR Institute. And they had written a paper saying that HCG is secreted by the day 3 embryo in the tube. And that is what upregulates the HCG associated factor in the endometrium. Okay. So based on that, we started giving it. After I spoke to him, we started giving it. And it was, and I also spoke to Dr. Mamta Deendayal, who had actually done the study with him. But what she said that was that the pregnancy rate improved a lot. However, there was a lot of miscarriage. So she had used, she had used 100 IUs. Then we reduced it to 50. So we are using 50, and that seems to be giving us good.
What is the volume of the media that you are taking, and how much, how you're pushing?
It's not given just the day. We are giving it on day 3 and then transferring it.
And then day 5, last you are transferring.
Yes. We are not doing it on the same sitting.
Okay. K.D. Nair sir, you have anything to share on this subject, sir?
No. Dr. Abha mentioned Sabina, she is working with me right now, but we are not using SCG.
Right, sir.
So you are using it?
So 1 out of 3, it's okay, sir.
Yeah, because Sabina only did this study of HCG intrauterine, and it did not show us. And we were, it is like Sonia said, no, day 3 embryos ke liye it was the most appropriate, not for day 5 blastocyst.
No. Put it on day 3.
Yeah, we
were not
transfer catheter ET on day 5.
Day
No.
5.
After embryo on
Then
day
it
5.
makes sense
Probably
actually,
it is
ma'am.
causing a proliferation of
Yes,
endometrium.
yes.
That is how
We
it acting.
did it on the day of OCR. We did it when the patient was still under anesthesia, and we did it only in fresh transfers for day 3. This is what the study comprised of, but we did not find anything, and so we never did
There's
it.
no sense in doing it in a fresh transfer, Abba, because you have already given a trigger of HCG. This is only for FET. In HCG, you have already given HCG.
I think it is also in fresh ones. I don't remember very well the study. Maybe Sabina would be there. She would tell.
Because that HCG effect is going to last for a week, no? So
But I remember we were doing it for day 3 transfers.
Sonia, Dr. Rashmi, her candidate did a thesis last year on the same SCG, and it was the same, both fresh and frozen embryo. She was putting this 2 days before doing embryo transfer.
It's recommended for failure cases only. As of literature, we have seen that.
In a fresh transfer, see, of course, the embryo, it is, what I'm saying is that according to Modi's paper, it is the embryo which is secreting it in the tube. And that is what is causing an upregulation of the factors in that.
Right.
But that is, basically, according to that study, they have clearly defined it that it happens from the day 3 embryo. So we were trying to simulate those completely. What you are saying is correct. Maybe it is there also in the fresh cycle, but I feel that because they are giving so much of HCG, it's not the natural HCG that we are giving. We are just giving what is produced. It is a chemical that we are pushing. It may not be what is exactly found in the body. So that's why I'm saying maybe it works, maybe it doesn't work. I don't know.
I remember because this was OCR. She used to pick up a chit and say, "Isme HCG dena, isme nahi dena," and then we had to sort of see that we do a fresh transfer for sure.
For frozen, we are getting good results.
Did you tell her to tell us what she did? Was it only fresh cycles, or did she also use it in frozen? You ask her; she'll tell us.
We are doing only in frozen.
Okay.
The next question can we have now? It's really good discussion. Ma'am, this is another query that we have. Progesterone on which dates? On the day of pickup or day of transfer? We just want to know your practical experience, because theory and literature we read a lot, but sitting with you all, it's such a pleasure today. So we start with Sonia, ma'am. Ma'am, progesterone on which day? Pickup or transfer?
What progesterone you start or what you test?
Yes, ma'am.
Support, progesterone support. Progesterone support has to be from the day of pickup, and the literature says that if the progesterone is not started within 3 days of the pickup, then the results are not good. So you can start it on the day of trigger. You can start it 1 day, 2 days, or maximum up to 3 days.
And
not from the day of transfer. Not from the day of transfer. It has.
I read it, ma'am, because they said the results were similar, because studies are 50-50, like 50 are for, 50 are against. So I think
no. If you're doing a day 2 transfer, yes, of course, it is within 2 days of the pickup, isn't it? But if you're doing a day 5 transfer and you start progesterone on day 5, you won't get results.
Because they say when you're stimulating the cycle and you're giving HMG, body is already producing progesterone.
No. If you're talking of a fresh one, yes. The body is already producing, and you have also given a trigger. What is the trigger meant for? It is basically going to, improve the sort of, it is going to let the progesterone come out from the corpus luteum. It's going to help. It's a rescue kind of a thing. So there you may not give it. Some people don't give any progesterone at all. But then I was talking to you.
Frozen embryo.
Yeah. If you have to start progesterone, it should be within 3 days. You have to sort of think of when you would be giving a trigger, what would be your day of trigger. And as Abba said, as soon as you find that the progesterone is rising to 1 or above that, 1.6, or she was mentioning something like that, that is the time when the oocyte has actually ruptured and you are finding that there is progesterone. So based on that, you're simulating that, isn't it?
Okay. So Ava ma'am, can you answer any difference of opinion? Or
I start progesterone in fresh transfers next day of OCR.
Yeah.
From the next day of OCR till whichever day we are doing a day 3 transfer, day 5, progesterone is always supplemented in our cycles from the next day of OCR, maybe the night, maybe the morning, whichever.
Why do you do that, Abba?
Because we like to give luteal support, because these are stimulated cycles.
Yeah, but then why not on the day of pickup?
Yeah, you read a lot of papers, and from that we found that if it is given after a day or two, like you say, no, within 3 days of the
within
pickup.
3 days. Yeah.
So they also said that people start 2 days after, because we don't do a day 2 transfer. Very rare. It's done only koi bahut hi kharab ban raha hai, and we just have to complete the cycle. Otherwise, day 3 or blastocyst transfers, day 5 are done as fresh, day 6 are frozen, and we do it in a FET cycle. So we started next day.
Yeah,
एक बार हम लोगों ने शुरू किया कि after the next day शुरू करो, but then I got a little jumpy with that, so I started next day of
started from the day of trigger. I started.
No, not from the day of trigger.
Sorry.
Next day.
Pick up.
Next
I started on the day.
Yeah.
Generally, the same. We are following the same because progesterone window is for 3 days, like the mentioned. It is for 3 days.
So you can start it next day or even the next day morning.
Or the day after, like
even day after morning you can start.
We are starting on the day of pickup because we want to be sure that
that the patient has started.
One number is to start 50 mg on the day of pickup and 100 from the next day.
I don't give injections at all. Zero.
Then, okay.
Good.
So we have 400
vaginal progesterone, and it is always 400 milligram for IVF patients, BD.
400 BD.
So next 4 questions we will have just brief answers because I think we are running short of time. Any experience with intramyometrial embryo transfer? Any of you, ma'am?
Dr. Kochar did once in one of her cases.
I have done 3. I have done 3.
What was your experience, and from where do you get that catheter for intramyometrial?
Oh, it is with Cook. You get it from Cook. It's available with Cook.
And what was the result, ma'am?
In 2 of the patients, we got a pregnancy which did not carry at all. No, it didn't carry. We had it just did not grow. And the 3rd one did not conceive. Otherwise, I would have reported it.
Right, ma'am. Better luck for next time. Thank you so much, ma'am. And next question is, I think ma'am touched it partly. Blood on catheter tip. Okay, do you use any specific media for implantation? Ava ma'am, Sonia ma'am, Kirina sir?
Yeah, I think this is how the media which is used by embryologist has all the embryo glue and everything in it. It is for everyone the same.
Nothing specific for recurrent failures which we are using, ma'am?
Already we use the specific one for every case.
Right.
It is the same hyaluron rich media.
Yeah.
It's supposed to adhere the embryo. Whether it adheres or not, we don't know.
Right. Okay, so next question was blood on catheter tip or outer. Sometimes we come across that whole outer is filled with blood and we really don't know. Maybe we were traumatized during pickup or something. So, blood on the tip of catheter indicates what? The inner catheter.
You've touched the myometrium somewhere, no?
Somewhere, and we've traumatized. And that doesn't...
Just like an IUI. When you touch it, you get it, and the patient also winces when you touch the fundus. The patient always says like that, and you find that there is blood on the catheter even in an IUI.
And there is no pregnancy in those cases, ma'am?
Yes.
Blood on catheter sometimes does have pregnancy. The only thing is retained embryos nahi hone chahiye. When the embryologist sees them and you have retained embryos, then there will never be a pregnancy. But you can have blood on the catheter and still the patient could get pregnant.
Outer catheter में pregnancy ज़्यादा आती है, inner catheter में कम आती है.
You sound so positive and you make us so comfortable. Ma'am, one question which has been circulating in all the groups. Fluid in endometrial cavity during transfer, fresh or frozen. So this you have to answer. What is the remedy for that fluid? Because once we see fluid, we are really not, we are very uncomfortable.
Very thick endometriums have fluid in the cavity. Sometimes when you do a non-stimulated cycle also, and if there is fluid, then this is the height of, height of proliferation where some secretions start, unless it is pathological and it is inflammatory. So you have to investigate it. If there is fluid and if still fluid comes in and there is no infective pathology, you ignore it. If it's too much, you aspirate on the day of transfer. But if it's little, then you just ignore it. We've been petrified with this. We've taken it out. We've tested it. We've done everything. And eventually we reached a conclusion that just transfer your embryo.
So do we make transfers in this, ma'am? Because I feel, I don't know. Sonia ma'am, do we get results? Abha ma'am gets results everywhere because that's a magic touch, but we don't get results.
No. ऐसा कुछ नहीं है. ऐसा बिल्कुल कुछ नहीं है. But yes, we have had fluid and we do get intrigued by it कि क्या करें इसका,
लेकिन
लेकिन उसको निकाल लो, उसकी जांच कर लो, उसका कल्चर कर लो, उसका सब कुछ कर लो, और अगर लगता है कि कोई पैथोलॉजी नहीं है और अच्छा ट्रिपल लाइन एंडोमेट्रियम विद फ्लूइड है तो ट्रांसफर कर दो।
मैम 2 दिन पहले कुछ नहीं
होता। Basically, when you are doing to ET, if you find a fluid, you have to aspirate and send it for culture and this thing, and maybe for the next cycle.
Yeah, you can do that. Correct. If you've not investigated, but next maybe दिखेगा तो
next में दिखेगा, then you already have the culture.
Yeah, you already have all the investigation. You can go ahead.
Sonia ma'am.
Go ahead. मैं तो आप go ahead. Agar if it is persistent fluid, no?
Yeah.
Then what can you do? You can't do anything. And I will give you a very interesting example, which you should remember always.
Right.
We aspirated the fluid and it was all semen. So remember that, you know. Remember, this is also possible. Yeah.
Anti-climax ho gaya, ma'am.
So
Sonia, similarly,
therefore I'm saying, please be very careful and ask the patient.
Similarly, in one case, we did not do an embryo transfer, saying embryos are poor quality. So we will make embryos again. And she came pregnant in that cycle, and she said, yes, I had intercourse one day before the HCG was given.
Absolutely. So you have to be careful about this also, you know.
I think, ma'am, we end up with my questions. Dr. Sonu, any questions from audience you can take, because we are really lucky to have such experts today. I'm feeling so happy and excited. So please take up few questions.
Can I just, chalo, pehle khatam kar.
Ma'am, please carry on. I think we have already covered all the questions.
Ma'am, one little remark for all of us. I'm sure Abha is going to agree with me, that we should now try and move more towards stimulated embryo transfers as far as FETs are concerned, because we are finding a lot of problem with the HRT cycles in the babies. So the world is moving towards ovulated, natural cycle or minimal stimulation cycles. And like Abba said, even gonadotrophin stimulated cycles, because you're finding so many obstetric problems and problems with the baby also in FET cycle. So that is one thing that we all must remember and try and do if we can.
FET cycles are associated with more eclampsia and preeclampsia. So in these cycles, when you get a dual marker, please do a PET wala screening also and start aspirin for them, where you've given HRT. And the only thing is the ease, that you don't have to call the patient and you don't miss out on ovulation, because if you miss out, then you can't transfer that cycle. Progesterone window is long. We can take.
Ma'am, I just wanted to ask that, like in a natural cycle, if we are doing an FET, so if there's a dominant follicle and the endometrium is very good, that day we can give a trigger and then maybe we start progesterone and then
you can cut down, do a LH also for her that day. And if LH surge has not started,
natural cycle.
You can do a modified natural also. That is also possible.
Because
if your Sunday is falling in between, you can always give her an antagonist and then do a natural cycle modified. But generally, you see, because we are going to do a day 3 transfer or a blastocyst transfer, there is no need to skip the Sunday, because the embryo transfer is not going to fall on that day. Only thing is, you should be sure that she can have a scan done either with you or somewhere to document the ovulation and get her LH, as Dr.
LH is very important.
LH is important, but also remember that the LH surge is not going to last more than 24 hours. It's going to rise 12 hours and then fall. So if you miss that piece,
our regime is फॉलिकल आज 18 है, E2 प्रोजेस्टेरोन LH कराया, और उसको बोलो तुम कल और परसों भी एक ब्लड टेस्ट कराओगे, LH प्रोजेस्टेरोन करा लो, E2 मत कराओ, and you will see the rise of LH, you will see the fall, you will see the rise of progesterone. It's so nicely, it covers, it's just 3 days of blood test sitting wherever you are in that city, in that place, and the day you find progesterone has risen, come back, have a scan and get the embryo transfer scheduled for yourself.
But ma'am, can we just like if we just give a trigger and we don't even see ovulation and we start her progesterone 2 days after, so then we can just
but Sonu, do a progesterone level on that day after 48 hours. HCG trigger जो urinary देते हैं, उसमें 1-2 patients हमारे IUI में progesterone was less than 1. And we were surprised कि HCG क्या नकली था. फिर हमने कईयों को ओबिट्रिल दिया, लेकिन उसके बाद वो प्रॉब्लम रिकवर हो गई, उसके बाद प्रोजेस्टेरोन राइज होने लगा. तो कभी-कभी ऐसे बैचेस आते हैं कुछ HCG के जिसमें
प्रोजेस्टेरोन राइज. We have published a paper on LUF with pregnancy we know it naturally also कि LUF होता है patient को हम कह देते हैं LUF है ये फिर भी
LUF में प्रोजेस्टेरॉन तो राइज होगा ना,
of course
ट्रैप हो जाएगा। प्रोजेस्टेरॉन राइज अगर हो गया तो कोई प्रॉब्लम नहीं है।
Don't have to worry. तो अगर तुम्हें लगता है कि एंडोमेट्रियम भी थिन है, add a little estrogen to that and then letrozole cycle में कभी-कभी करना पड़ जाता है। And of course, as you go on, you can. I mean, Dr. KD Nair सबसे ज़्यादा quiet है। हम 2 women बोले जा रही हैं। Please, Dr. Nair, it is your turn now.
No, I'm listening to you.
चलो।
No, ma'am,
actually, ma'am, there are questions from audience, but most of the questions have been answered, and this will be available on a YouTube channel also. So most of the audience, attendees have asked the questions which you have already answered. Abha ma'am, Sonia ma'am.
एक मैं बात कर लूँ, उसमें एक tuberculosis पे था question.
हाँ जी मैम, they're saying endometrial preparation in
Contrary to Wali ने पूछा doses and regime of tamoxifen by Dr.
Yeah, Dr. Abha बता दें, please.
20 milligrams twice a day for 5 days, starting from day 3 to day 7. Maximum dose is 20 milligrams 3 times a day for anovulatory PCOS, but for patients who are ovulating and you want to make a cycle, FET cycle by ovulation, then 20 milligram twice a day.
Dr. Ritu has asked, ma'am, tuberculosis you wanted to answer, Sonia ma'am?
No, I'm just saying she has asked us. This is our favorite pastime, no? Abha ka aur mera, isliye main
I know.
So the question is endometrial preparation in patients
Today
who have...
it's not going to be my pastime. This COVID is not letting me sit happily.
Okay. But it is the worst kind of endometrium to treat,
Yes,
tubercular.
I agree.
At the same time, there are patients who will respond if they get cured after AKT. Once you've given them a full course of anti-tubercular treatment, they may have responded and you will get a pregnancy. So there are both kinds of patients. We cannot say that every patient is going to fail. So the endometrial preparation remains the same, but the only thing that we all have to remember is, that's why I said I should answer this question. If you are giving rifampicin to the patient, while the patient is still on rifampicin, if you give her estrogen, then her endometrial proliferation is not going to be up to the mark, because an estrogen is actually, there is a cross reaction between rifampicin and estrogen. So please
remember, this is also true when patients are put on ATT and they are asked to go try conceiving. There also the endometrium becomes suboptimal and the chances of conception may be lower during that time. So it is best to finish ATT and then only ask them to try.
But again, there are so many patients who do conceive while they are on ATT.
Yes, they do.
There are
because hormones also have a liver metabolism, and also ATT, all the drugs go through the liver. And that is why liver functions go haywire. One more word about this now, when you brought this topic in. I have had a patient where the endometrium continued to be thicker on day 3. For 2 cycles, I gave her progesterone. Then I said, no, I'll do a hysteroscopy before the embryo transfer. She had 4 or 5 good embryos. I did a hysteroscopy DNC and she turned out to be tuberculous endometritis, and we had to give her full treatment. After that, the endometrium came back to normal, but she's not implanted till now.
Yeah. So again, the problem is not just the microscopic picture. No, it may be beyond that the whole thing has affected it. The inflammatory markers may still not have recovered. When I was so fanatic about doing tuberculosis in my practice, I used to find that, even when the endometrial biopsy used to be negative for PCR tuberculosis, it used to take about 4 months for the patient to conceive. They did not conceive before that because probably the inflammation takes that much time. Now we know this from COVID. We know that even when, the PCR in COVID is negative, the CRP remains positive for a longer time. And also the IL-6 remains positive in COVID. So similarly, even in tuberculosis, the TNF alpha and the, interferon gamma, they remain high. So that may be the reason why patients don't conceive even though they seem to be having a good endometrium. So tuberculosis
this is in 2 cases of tuberculosis which are proven by histopathology and by culture.
But not only that, Abba, now, of course, we are doing immunohistochemistry also, CD138 also. So it's a lot of things have happened.
It has to be in the phase of the whole clinical scenario also of the patient, clinical picture.
Yeah, the best is let the patient finish the whole ATT.
Yes,
yes. Hurry.
But doctor, there is a subgroup of patients where they have recurrent pregnancy losses and tuberculosis, endometrial tuberculosis with recurrent pregnancy loss or recurrent implantation failure. There you cannot stop it. If you stop it, she'll again fail. She'll again have it, unless you keep on giving her till all her inflammatory markers are correct. There is a different type of patient who starts. So that is what I'm trying to say. The immune problem with tuberculosis is something that we have understood very late. And that is what is actually the problem, not the TB PCR. Chaliye, aage question
This was the accident discussion, ma'am. The chat box is filled with all the compliments, and I think everybody's enthralled with the discussion. And this should have gone forever and ever and ever. Oh, dil abhi bhara nahi. But I think good thing comes to an end, and so we conclude with the thanks on behalf of Indian Fertility Society Haryana chapter. A special thanks to Abha ma'am, who in spite of all her illness but her willpower is something that is to be followed by everyone. Thank you so much, Abha ma'am and Sonia ma'am. It's always pleasure to look at ma'am's face and sab khatam. And thank you, K.D. Nair sir, and our dynamic secretary, Dr. Sonu Balhara. She's such a polite, intelligent.
No, nothing to thank me, ma'am.
Dr. Neeru, Dr. Pooja, Dr. Shalu, Dr. Priya, and everybody who could make it today. And a special thanks to Deepika ji and our team for all the wonderful company, and she bears with us for long duration of time. And we have Dr. Sonu from Nepal. She always joins our webinars. And Dr. Sonu, if you could join us and speak to everyone.
Before that, I would like to thank Abha ma'am, Sonia ma'am, and KD sir. And we will be troubling you throughout the year for such discussions, ma'am. Thank you so much.
My privilege. Always it gives me a chance to read a little more.
Good discussion, ma'am, we had today. Like chat box is yes, Dr. Sonu.
Yes.
Your video, can we have a look at you?
Shalu, are you also not well? Shalu's
Hey,
also.
ma'am, I'm fine.
She's got the booster today.
Okay.
I got the booster on 31st. And I got the infection on Sunday.
So I didn't have time to work.
I don't know.
Maybe I just got booster. So
booster se kuch nahi ho raha hai. My daughter got a booster 1 month ago, and all of them were down with Omicron ke against. ये booster नहीं work कर रहा है.
This is not working.
हम booster तो normally लगवाया था, just for क्योंकि सबको लग ही रहा था.
सबको लग रहा है ना.
हाँ.
और हम तो आउट ऑफ टर्न 31st को लगा लिया कि हमें नहीं हो ओमिक्रॉन, लेकिन ओमिक्रॉन के लिए कुछ नहीं काम कर रहा है. But it's not very severe. I could sit across through the whole session for 1 hour.
Some of the doctors have got in all the three phases, all the three waves.
Yeah, mine is the first one. And the wildest phase.
I got the worst in the last one, so I'm all right now.
Yeah, second one was the worst.
I got it, so I'm mera share ho gaya. Shayad. I don't know.
Hello, Dr. Sanu.
Oh, there
yes,
she is.
we can see you now. Dr. Sanu, ma'am, she's from Nepal and she invites us every time, but the COVID stops us every time.
Yes, namaste. It's very nice discussion. Learn a lot information. How are you all doing?
Very much, everybody. Can I leave, please?
Thank you, ma'am.
Nice to be with us. Thank you. Thank you very much.
Thank you. Thank you, Abha ma'am. Thank you, Dr. Sanu. Thank you, Sonia ma'am.
So, yeah, hope to see you soon. April 2nd, 3rd ko hai. You are all invited for the conference. Hope the COVID will let us get together.
Thank you.
Thank you, Sonia ma'am. Thank you,
Very nice, sir. Dr. Sonia Malik ma'am.
Thank you very much.
Thank you, everyone.
It was great fun. It was
Nice
fun.
to see you, Dr. Sonia.
Thank you.
Very nice, sir. Thank you, Sonia ma'am. We really enjoyed it.
See you soon.
Thank you, ma'am. Thank you, Deepika ji.
So we can end meeting now.
Yes. Thank you.
Very nice.
Thank you.
Very nice meeting, Seema. Very good.